Dr. PT Christine Pieton is on now. To participate, call 1-800-375-2872 or email askme@drptpodcast.com. This is Dr. PT
Welcome
Christine
back to the
Pieton.
Dr. PT podcast. I'm your host, Dr. Christine Pieton, an orthopedic and pelvic floor physical therapist. This show is for you to be able to call in or send me an email about those common aches and pains that are holding you back. And what's not so common is knowing what to do when they do pop up. That's what I do every single day in my office with patients, helping them to better understand those common aches, pains, and pelvic floor symptoms that are popping up for them, and knowing how to better treat those symptoms so that they don't keep interrupting your day-to-day life. So over the last few weeks, we've been doing different episodes where I've been sharing different topics so that you can learn about your body. We've covered the pelvic floor, your back, knee pain. We've talked about foot and ankle things, amongst many other pieces. So today is going to be a compilation episode where I'm going to try to answer as many emails as I've received over the last couple of weeks, because every single episode I answer a few, but I can never get to all of them in my inbox. So I've curated a special compilation for today, also because today is the last episode of season 1 of the Dr. PT podcast. So I'm really excited that we've been able to do this many episodes and hopefully help you learn and know a little bit more about your body and to be more curious and excited to know how to better care for it. So in today's episode, you can still call in and ask me those questions. If you've been too shy, be sure to call in today. It's going to be your last chance for season 1. Our phone number is 1-800-375-2872. Again, that's 1-800-375-2872. So I'm going to dive into emails as we wait for calls to come in. And our first email is from Crystal, and she said, I watched your knee pain podcast, and something that you said really resonated with me. I'm 46 years old. I'm a former competitive bodybuilder, and I injured my left knee during a simple workout back in 2022. I've done nearly 2 years of physical therapy, and my MRI showed only mild arthritis, but my knee still intermittently gives out, especially on stairs. And I've had to stop riding my motorcycle because of it. She said, while in PT consistently, my knee feels really stable. Once I stop, symptoms return. Is this something that requires ongoing maintenance of PT long term, or does this pattern suggest something deeper that might be getting missed? I love that you're thinking about this from a few different perspectives, Crystal. So first, some of my questions would be, what have you been finding helpful when you are doing consistent physical therapy that's helping your knee to feel stable, as you mentioned in your message to me? Sometimes people will be really diligent in PT. They'll be working on the things that they need to help their body feel better. And then naturally, this is very human for all of us, when we start to feel better and we don't have those symptoms anymore, we can sort of kind of fall off the wagon in terms of the maintenance that we might need to be doing to keep our body feeling our best. So is that happening for you? Maybe we have some specific exercises that you find really helpful when you're in PT consistently. Having the accountability of going to those appointments keeps you on track with those things. But as soon as we don't have those accountability appointments on the calendar, does our accountability to ourselves fall off? That would be one question. Another thought is also saying, hey, is what's helping you feel better in your PT sessions more of consistent kind of manual therapy or soft tissue work, massage work? Is that what seems to be helping you in addition to you doing your PT exercises and things like that? And when that manual work isn't as consistent, are we noticing that your knee doesn't feel as stable? Is it, maybe locking up, things like that? So sometimes we do need some kind of ongoing maintenance. I don't know why it's not commonly recommended that we have regular tune-ups for our body with a physical therapist on our medical team, like we're supposed to have regular tune-ups for your annual physical. Also, we should be taking our car in for regular maintenance, all these things, not always waiting until it breaks down, right? Our bodies should be no different. So yes, I even have some patients on my schedule that see me for quarterly maintenance, for monthly maintenance, for whatever amount of maintenance feels helpful for them to feel good and being able to stay active. So yes, sometimes we need a little bit of that. A few other things that come to mind for you, Crystal, are you say that the biggest issue is often when you are navigating stairs. So does your strength and gym program mimic that movement? Are we doing step-ups? Are we training step-downs? Are we incorporating those things that challenge your knee in day-to-day life where you have symptoms? So often I'm saying, hey, we start to avoid the things that bother our body. But if we want to have capacity for those things, we need to be training for that. So my patients that have issues with going up and down stairs, I don't avoid stairs with them. We need to gradually work into them. So I may start with very shallow step-ups. I might then progress to a stool. I might then actually take them outside my office and start to train on some of the stairs that lead up to my practice. So these are other things that we need to also be incorporating and practicing. And sometimes I'll even have patients do this and navigate up and down stairs to a metronome. Why do I do that? So a metronome that many of you might think of for music and keeping to a beat, right? A metronome can actually be a really helpful way to train coordination and also so that we can get out of our own way when we're anticipating pain or anticipating a particular movement that has brought aches, pains, instability to be brought on. Because when we have a history of that and then we go to practice that activity, it is very normal for our brain to kind of freeze. All right, so part of rehab is also helping our brain to turn down the warning signal that it previously needed to use when there was an issue. But sometimes it keeps deploying that warning signal even if we don't actually need it. So distracting our brain with having to listen to a metronome and time their step up and their step down to the beat can be a really helpful strategy that I'll use with patients. And you can use this yourself. Even if you're in the gym, you can have your headphones in, use a free metronome app, and use a timing method for a few sets and then try to practice it without the metronome and being able to work up to that without needing the audio input to be able to coordinate that motion well. And then lastly, when we're having knee stuff and especially on stairs, we have to make sure that our hip and our ankle are also moving well. Because if they're not moving well, then that's eventually going to overload the knee, and that can lead to instability and the knee giving out if it's being asked to do more work than it has the capacity for. So if we've made sure that we're ruling all of those things out, Crystal, and we're still having the issues with your knee that you're mentioning, then I would recommend getting some updated imaging, because I'm going to make an assumption. You said that the injury originally happened in 2022. And so I'm going to assume that that was around the same time that you probably had imaging for your knee. And so it may be time a few years later to get some updated imaging. But I think there's quite a bit of some strengthening and other pieces, like I mentioned, to explore first. So I hope that gives you some additional insight to take a look at what's going on to help your knee feel better. So next email that I have here, it says, hello, I am 3 weeks into a non-displaced fracture of my lateral condyle of my left femur. I'll translate that for anyone who doesn't know where the heck that is in your body. So if you think about your thigh bone, if you take that thigh bone all the way down to the point where it is part of your knee, the outer portion of that knee is roughly the neighborhood of that lateral condyle. So this individual says that my orthopedic doctor has me non-weight bearing for 8 weeks. Yeah, unfortunately, this is what has to happen for a number of weeks to give our bones time to heal. She says, I can bend and straighten my knee without any pain whatsoever. That's awesome. She says, I'm a very active 70-year-old woman. I feel my left leg is getting really weak very quickly because of not being able to bear weight on it. At what point would you recommend starting physical therapy? So, Lynn, I'm so glad that you're asking this question. First and foremost, we cannot do any physical therapy until your doctor clears you. So step number 1. And that clearance is really important right now because we've got a bone that's healing. We do not want to prolong that healing or possibly make it worse by putting any load onto that area before your bone is ready. So as soon as your doctor clears you for PT, start right away. And yes, the unfortunate piece is that we do lose a lot of muscle when we are not allowed to use any part of our body. And unfortunately, that starts to happen within days of us not being able to use our body or taking a few days off. If any of you have ever had that happen in your life where you're regular with your workout, life happens, maybe you went on vacation, maybe we get sick, whatnot, we come back, a week, 2 weeks later, and we're like, dude, why do I feel so much weaker? Because we lose strength in just a few days. So the good news, though, is that people who are motivated and like to move their body usually are willing to put in the work to make up for it. But it takes quite a number of weeks to regain the strength that we lose, especially when we have to be non-weight bearing for 8 weeks. So Lynn, I highly recommend that you stay diligent with your orthopedic doctor, asking them when they think that you are going to be cleared for PT. And if they are able to give you your referral for physical therapy so that you can start to reach out to clinics in your area and get on the schedule, because sometimes there's a few weeks of a wait before you can get in, depending on the area that you're in and how many physical therapists are available. Here in my area, we actually have quite a number of weeks that usually people are kind of delayed from the time that they call and want to schedule to when they can be seen. So that could be one question to ask your orthopedic doctor, if you can have that conversation, see when they think you might be cleared, and if you can start to kind of maybe get something put on the calendar. So that's there for you to delay any other waiting in between when your doctor says you're good to go to PT, so you can start as soon as possible. All right. Next question. So this one's a little bit longer. So this is from Jan. She said, my husband sometimes has bowel incontinence. Background, he is 75. He had his prostate removed in 2020 due to cancer. He had full bladder incontinence and did get a referral and saw a pelvic floor physical therapist. He had some improvement and eventually needed to undergo an artificial urinary sphincter procedure. And there's some additional history here that said that there was more than one surgery in this particular area. She said he still occasionally has some manageable urinary leakage, but has now developed bowel incontinence. He has diarrhea, and sometimes it's worse, sometimes it's better, and it does unfortunately create some embarrassing situations. He alternates between constipation and diarrhea. Would physical therapy, pelvic floor physical therapy, be helpful? She said, I'm enjoying your podcast. I've been doing Pilates with a physical therapist for several years, and we do a lot of pelvic floor strengthening, and I rarely have any issues with my pelvic floor either. I really appreciate it. And she said, your first podcast gave such a clear visual example of the pelvic floor and how everything works together. I will never see a yellow balloon again without thinking about my pelvic floor, LOL. So if any of you missed my very first episode, I used a demo and a visual of a balloon with the pelvic floor to explain how everything kind of works together. So that's what Jan is mentioning, and I'm so glad that you will always think of me now when you see a yellow balloon and your pelvic floor health. So back to the original questions. Would pelvic floor physical therapy be helpful for Jan's husband in this case? My answer is a resounding yes. So a couple of things here. When we undergo multiple pelvic surgeries, we are going to have scar tissue. We are also going to have weakening of the pelvic floor muscles and the surrounding muscles around the pelvis, because anytime we undergo a pelvic surgery, there's often a number of weeks where people are on what we call lifting precautions, meaning that you can't lift X number of pounds for a number of weeks. And it's usually pretty low. It's somewhere around 10 to 15 pounds for usually about 6 to 8 weeks is a pretty standard window. So like the previous email that I just mentioned about someone having a fracture and not being able to bear weight on their leg for 8 weeks, our body loses a significant amount of strength after just a few days of not being able to lift and load our body. And the same is true after a surgery. So in this case, her husband has had multiple. So that's going to mean that we often are going to lose strength. And then unfortunately, it's not standard of care still to always refer someone to pelvic floor physical therapy if they've had a pelvic surgery of any kind. Fortunately, earlier on, after his prostate cancer, he was. That should be the standard. Unfortunately, that's still not always recommended or provided to the patient. So in the case of bowel incontinence developing later, or what we call fecal incontinence, right? This can absolutely happen when we have not regained full strength of our pelvic floor, and or if we don't have enough strength around the muscles that work with the pelvic floor of our hips and our abdominal muscles, okay? The other big piece here too is side effects of cancer treatment. So if we've had radiation and chemotherapy, this impacts the pelvic floor and the pelvic floor tissues. So they can become a bit more fibrotic, meaning less flexible. This can impact their strength and how they can generate and maintain good strength function. This can be improved upon with physical therapy and education, but we have to be doing extra work to be able to combat that. And can we always overcome all of those things? Unfortunately, no, but we can do the best that we can with the tissue and the quality of the tissue that we have left. The other pieces too, we often have scar tissue that can make it really difficult for that pelvic floor to be able to move well. And then this can also lead to urinary and fecal incontinence for some individuals. So these are just a few of the many reasons why, yes, pelvic floor physical therapy would absolutely still be helpful for Jan's husband, and why it should be the standard of care for everyone going into a pelvic surgery, and especially soon after. So I hope that that gives a little bit more context and encouragement to seek that out. Even if we already did pelvic floor physical therapy prior, seeking out that care again later on absolutely is still appropriate. So Jan, I hope that can help both you and your husband. Right. I'm going to go ahead and do one more email here. And I think that'll likely take us to our first break, but I'll see if I can squeeze in two. We'll do it there. So this message is from Lisa. She says, I really am enjoying your podcast. I have been trying to incorporate your tips into my daily exercise routines. I love that. She said, I have started standing on one leg and doing each leg for 30 seconds almost every hour during the day. And I'm doing really well, but I haven't yet mastered being able to do it with my eyes closed yet, but I'm working on it. Just wondering if you had a few suggestions of some good daily exercises that we could be doing to help strengthen our core and our pelvic floor. Can you please make a list of these daily exercises, or maybe drop a clip or two about how to do them correctly? My answer is yes. I have a lot of these on my YouTube channel, and a few that I would recommend more specifically for core and pelvic floor are the following. I have a Kegels in Motion series that is about 3 to 4 videos, depending on how many of them that you want to watch. And they progressively challenge you with each subsequent video. And then I also have a powerful pelvic floor and core program that is also made up of 3 videos, and they get progressively harder as you move through the series. And they have a lot of really good examples of daily exercises that I often recommend to patients, but also are really good, what I call multivitamins for your movement, things we should be incorporating on a weekly basis for your core and your surrounding hip muscles. So I would recommend checking those out. And for anyone that is also interested into what Lisa was saying, you can check those out too. And I will try to remember to link those in the description of our YouTube video here after the live stream so you can find them more easily. All right. And with that, I will choose to pause here because the next couple of emails are going to be a bit longer in answer. So we'll pause here. I encourage you, if you have questions and you would like to call in, you can still do that today, even though I'm focusing a lot on past emails that I haven't been able to get to yet. But you can give us a call here at 1-800-375-2872. And when I come back after the break, I will continue with our emails and answer any questions if there's anyone that's brave enough to give us a call in. I'll see you in a few minutes. As a doctor of physical therapy, I'm all about optimizing health and wellness. We start to lose collagen, the most abundant protein in our bodies, when we're in our 20s. And that really ramps up after 40. Native Path collagen can help replenish this essential protein needed for healthy bones, joints, skin, hair, nails, and digestion. Native Path is packed with the types of collagen your body needs most. With just 2 scoops a day, you'll get 18 grams of protein. It's completely flavorless and easy to mix into any drink. There are no fillers or additives, and Native Path is a third-party tested for purity. Get to getnativepath.com/drpt for a special bundle deal at a fraction of the retail price, plus free shipping. That's getnativepath.com/drpt. Feel better, look younger, and start your transformation today. I do not need a miracle in a bottle, just a product that actually delivers on its claims. And that's why I'm excited about Vibriant's Super C Serum. Super C Serum is designed to replace all the things people my age and older start adding to their daily routines, like day creams, eye creams, night creams, neck creams, wrinkle creams, and the dark spot reducers. It's created with the highest quality vitamin C on the market, plus hyaluronic acid, vitamin B5, vitamin E, and other trademark ingredients. It's gentle enough for sensitive skin, but guaranteed to deliver noticeable results, or they'll give you a refund within the first year. Simplify your skincare routine with Vibriant's Super C Serum. Go to Vibriance.com/DrPT to save up to 37% off. Plus, get free shipping. That's VIBRIANCE.com/DRPT. Vibriance.com/DRPT to save up to 37% off and get free shipping today.
This is Dr. PT Christine Pieton. To participate, call 1-800-375-2872 or email
Welcome back to the
Ask
Dr.
Me
PT podcast. I'm your host, Dr. Christine Pieton, an orthopedic and pelvic health physical therapist. In today's episode, I am doing a power through of past emails that listeners have sent into me that I haven't been able to answer in previous episodes. So if you are joining us partway through, that's what we're doing. And these range from orthopedic questions to pelvic health questions. And if you are catching us here live on the live stream, you are still able to call in and ask me questions here too. The phone number is 1-800-375-2872. So diving back into emails, our next email is from Sarah. Sarah said, I had borderline ovarian cancer and had all of my parts removed, uterus and both ovaries, fallopian tubes, and cervix. I was 47 at the time and went into surgical menopause. Right away, I had clitoral atrophy, and it changed my orgasms to be less strong and flowy through my body. Not so great anymore, and it has honestly made me really depressed. I'm 51 now and have been on an estrogen patch since 47. Is there anything I can do to help improve my pelvic floor and to get my orgasms back and to help my clitoris feel better? Thank you. Sarah, I'm so sorry that you had to go through all of that. And yes, surgical or what we call medical-induced menopause is a real thing. And the good answer, or the good news is yes, there are things that we can do to help you feel better and to support your pelvic health and your sexual health. So first and foremost, when we go into menopause or medically induced menopause, that significant drop in estrogen directly impacts our pelvic floor tissues. And this includes the clitoris, this includes the internal vaginal canal, and the hydration and the lubrication to these areas, which is critical for comfort and also especially important for intimacy, whether that's with ourselves or with another person. So first, what I want to say is the piece here that you said, I have been on an estrogen patch since 47. That is awesome. Patches are a systemic hormonal support. They are important for the organs of the body, but they do not help to improve locally at the pelvic floor level. At the pelvic floor level, we need what's called topical estrogen. And so based on your email, I think we have an opportunity here to add in topical estrogen into your weekly routine. Now, topical estrogen is something that is in a lotion that you would then be able to apply directly on the clitoris itself, around the surrounding kind of vulvar tissues, especially if they are dry or what the medical world calls atrophy, like a thinning or kind of a light sort of gray or white in color can also be a sign that we have some dryness and thinning. This is very common when we are in a low estrogen state, but can be supplemented with topical estrogen. And fortunately, in November of 2025, yes, that recent, we finally got the black box warning removed off of topical estrogen. So it is 100% safe for all individuals, regardless of whether or not somebody had a history of cancer. So this is another really important piece that unfortunately a lot of individuals who may go to a provider who hasn't been educated or informed that these things have been changed and we have research to confirm the safety of this, sometimes still won't prescribe topical estrogen to an individual who needs it. So Sarah, my hope is that you have a provider who can write that prescription for you, since you do have an estrogen patch, which is also a prescription based. So I would say whoever helped you to get that prescription, talk to that provider about incorporating topical estrogen for you as well. You could also explore what we call a hyaluronic acid suppository, and that can be inserted intravaginally. That can also be able to help just some of the dryness and the thinning and the discomfort inside the vaginal canal. And the clitoris is not just right at the top of the vaginal opening. It's actually wrapping and incorporated through the deeper portions of our vaginal canal and into the pelvic floor. So helping with hydration inside is going to be helpful as well as outside. Right. Other things that can be explored here, but again, would need to be discussed with your provider, are a DHEA topical formula that can sometimes be mixed in with the topical estrogen and different things to be able to help in these different ways. And then the other really big piece that I'm regularly recommending and encouraging my patients to explore is vibration. So using a personal vibrator to help externally as well as around the clitoris, depending on if that feels comfortable for individuals, as well as internally is going to be really helpful. Think about vibration anywhere else in our body. Vibration is really helpful for improving blood flow and circulation and relaxing tissues. And then also from an intimacy standpoint can be really helpful for orgasms. So all of this is really beneficial also for our pelvic floor. And the beauty is that we also finally in the pelvic health world have research that confirms regular weekly use of a personal vibrator along with the other things that I mentioned showed significant benefit for individuals who are in menopause, whether it's medically induced or naturally occurring, and that significantly reduced pain and discomfort and improved quality of orgasms. So orgasms matter no matter what decade of life that you're in. So these are all helpful things that hopefully, Sarah, you can start to incorporate and explore and or to discuss with a medical provider who has a background in this. So gynecology, as well as some gynecologists or urologists also have an additional specialty within sexual medicine. So these are other areas and providers that you can look for in your area. And then I will also put in a plug here for a particular urologist and sexual health medicine on Instagram that has a lot of really helpful information, Dr. Rachel Rubin, Rubin. She's been on a number of podcasts and things, and she's a huge advocate in this space. She's also one of the main people who helped get this changed with the FDA back in November of 2025. So check her out on socials or find her on some different podcasts. She's really, really great. So hopefully that'll give you some additional resources, as well as for anyone else who is feeling similarly to Sarah. The next email that I have here, this one also has a bit of a lengthy history, so hang in with me because this is really important and a topic that I am regularly counseling patients on in my office, so I know that there are other people listening that this will be beneficial for too. So it says, "Hi, I'm so happy that you are bringing a doctor of pelvic floor PT on to the podcast." This was sent to Dr. Laura, who forwarded this on to me. She said, "I have been working with gastroenterologists, colorectal surgeons, and pelvic floor PTs to help me with a group of related GI symptoms without much success. Hopefully, your expert can lend some insight. Here's my history briefly. I've had chronic constipation that has gotten more problematic as I've gotten older. I am now 72. This has led to significant rectal prolapse and a weakening of my pelvic floor, which the colorectal surgeon does not want to repair until I get the constipation under control." His words. "A typical day involves trying to go for a few hours to empty my bowels, only to be followed by loose stools that have been explained as overflow diarrhea. I am also suffering the humiliation of fecal incontinence. Prescription meds for constipation and over-the-counter laxatives only make the diarrhea worse. Do you recommend a better course of action for pelvic floor therapy? What I'm doing right now hasn't been helping the symptoms at all. Thank you in advance for your thoughts." So, Beth, I'm so sorry that you're navigating all of this. And these are really common symptoms that many people start to experience for a variety of reasons in their life. So a few things that come to mind. Number one, yes, I hear the colorectal surgeon saying that they aren't recommending a prolapse surgery until we get the constipation under control because there is a very high failure rate post-surgery if that continues to be the case. However, when constipation is the issue that's also preventing us from being able to get the surgery that we might need, that deserves an extended conversation. So a few thoughts. Number one, if it's possible in your area, I would also say, hey, can we see another doctor for a second opinion? That may be another colorectal surgeon. That might also be a urogynecologist. A urogynecologist is also a medical provider who does surgeries for prolapse. So that would include a rectal prolapse as well. Getting another opinion can be really helpful for any significant surgery anyone's going to be going through, but I would especially recommend, if we could, can we see another provider to get an updated recommendation for your situation? I would also say the same for your pelvic floor PT. If you've been doing pelvic floor PT and it's not changing, couple of questions I have. One, Are we just doing internal work, meaning soft tissue work, trying to release tension throughout the pelvic floor, or are we also doing exercises and strengthening off the table? If you've just been doing pelvic floor PT and it's passive, meaning you're not doing active work or you're not getting off the PT table and doing strengthening work, number one, we need to be having that. And number two, I would recommend having that conversation with your current PT, asking, why are we not doing some of those things, or are we working to those and getting a better idea? Or if your current pelvic floor PT doesn't have those skills, then I would highly recommend getting another pelvic floor PT who does. When I work with patients, yes, I do some work on the PT table, assessing things, doing some manual treatment when needed. And then we need to get everyone up into standing, into vertical. We need to be moving and strengthening because that is where real life happens. That is where symptoms happen. And we need to be working on improving the strength of the pelvic floor and our surrounding hip muscles in the positions where gravity is on our body all day to make sure that we have enough strength and coordination for all of these things. And that includes when we are trying to strengthen the pelvic floor and manage constipation. The other piece that I am also curious here is, Beth, are we using a squatty potty when we are on the toilet? So a squatty potty is a really important device. It's basically kind of a specialized stool that goes underneath your feet to help put your body into a better position to ease bowel movements more easily. Sometimes individuals haven't even heard of this, even if they're going to pelvic floor PT. So squatty potty would be one recommendation. There's also a device that I recommend for patients who have a more severe prolapse. And for those of you who don't know what a prolapse is, in this case, the rectum, so inside of above the pelvic floor, is collapsing into the vaginal canal. And what that means is then stool can kind of pocket there and make it really difficult to fully eliminate each time we go to the bathroom. So a device called a Relieve, R-E-L-E-V-E, is a specialized device with a handle that is inserted intravaginally to kind of splint the vaginal wall that can then allow for an easier process of being able to pass a bowel movement when we have a significant prolapse. So this would be another device that I would highly recommend exploring. You can order them online, and that can give a lot of people a helpful tool to be improving their constipation. And then hopefully that can also make you feel better and not have to be on the toilet for significant amounts of time, because that also adds extra stress and strain to the pelvic floor and our mental health. All right. So these are just a few things, hopefully, Beth, that can give you some additional insight into how you might want to be exploring this situation differently and having some additional conversations with other providers in your area if that's possible. All right. Next question. So here I have a message from Mariana, and Mariana says, I've been seeing a lot of ads about gluteal tendinopathy. Is this related to pelvic floor problems? I'm a 74-year-old woman. I was told a few years ago that I had sciatica by a PT, but it doesn't seem to fit my symptoms. Another doctor, an orthopedic surgeon, said it was my IT band that was inflamed and he couldn't help because it was soft tissue. Anyway, the gluteal tendinopathy seems to fit best. What is your opinion? So in terms of gluteal tendinopathy, this is tendinitis of the glute muscles, which are going to be kind of basically on the back side of the hip and also on the outer side of the hip. So the kind of general location for most people is going to be kind of on that outer side of the hip. So think if you were lying on your side, that kind of hip bone there is the general neighborhood where people will usually have symptoms if they have gluteal tendinopathy. And so based on the fact that Mariana was saying, my orthopedic surgeon said that it might be my IT band that was inflamed, the IT band actually runs up and inserts into the TFL muscle, your tensor fascia lata, and that tensor fascia lata is in that same neighborhood and connects into some of the glute fibers. Some of the glute fibers also insert into a portion of the IT band. So I'm with your orthopedic surgeon and kind of that neighborhood, and what you were kind of defining is likely more the gluteal tendinopathy rather than sciatica. Sciatica tends to be more kind of running symptoms down the back of the leg. It can be into the buttock. It can be into the thigh and all the way down to the foot. But based on what you were mentioning and things like that, I'm also more in the camp of saying it's probably the gluteal tendinopathy. Can these be related to pelvic floor problems? Yes. Are they always coexisting with pelvic floor problems? No, not necessarily. But if someone has pelvic floor symptoms, and a lot of times that can cause people to pull back from activities, not stay as regular with their exercise because of those interruptions of embarrassing symptoms, those kinds of things. Can we start to lose strength in our hips and surrounding muscles? Yes. Can that lead to overloading the glutes? Yes. Can that lead to tendinitis? Yes. So can we have gluteal tendinopathy? Yes. But they don't always have to correlate with one another. So I want to be clear on that. But the good news is, how do we treat gluteal tendinopathy? With hip strengthening. Does hip strengthening help our pelvic floor? Yes. So the good news is strengthening in general will help both cases. So what I would definitely recommend and say is that PT, if you have one in your area, would be helpful to explore to kind of confirm that, hey, is this really what we think it is? Because I'm making an educated guess based on what you emailed. The other thing too, like I mentioned, if we can work on some hip and some core and some pelvic floor strengthening, that would often be first line of defense. And I have those videos also on my on my YouTube channel. And in a previous question that I already answered, the same exercise series would apply. So like I said, I will link those in the description after this live stream so that you guys can find those a little bit more easily. But I have a lot of different hip and strengthening exercises on my YouTube channel in general. So I recommend checking those out. And then lastly, I would also say too, when we have hip things going on, I'm highly suspicious, not just at the pelvis, but I'm also looking down the chain and saying what's happening or not happening at that foot and ankle down below. If we have a foot and an ankle that aren't moving well, and I should also be clear, a big toe, your very first big toe, if that can't bend well, that's going to lock up a foot and an ankle. That can start to create issues up at the hip. Okay, so we need a foot and an ankle that can move well and that is strong. If it can't move well, then we don't have a good platform to be loading our body on while we're doing our day. And so the body is going to compensate for that. And it's going to start to tighten up other muscles further up the chain to try to do that job. And so one of the really common places is going to be the glutes, as well as the other muscles that insert down the IT band. And then this starts to create other issues that create pain and discomfort on the outer side of the knee. And that will often then travel all the way down eventually to the outer side of the ankle because they all coordinate together. So yes, we need likely some strengthening and support at the in and around the area of your hip, but then also don't forget to look further down at the foot and the ankle or have a PT help you with that to improve your platform down below so that your hip and your foot can move better together and everyone can help distribute the load rather than one area getting overloaded and getting pissed off. Okay? So look at the hip, help strengthen around the pelvis, but then also don't forget the neighbors. Okay? So I'm going to take a break here, and when I come back, I will try to finish the rest of my emails. I'm actually impressed with myself. I'm doing pretty good. And then we also have another comment that I'm seeing here from the live stream, so I will make sure to answer that as well. I'll see you when we come back. I do not need a miracle in a bottle, just a product that actually delivers on its claims. And that's why I'm excited about Vibrian's Super C Serum. Super C Serum is designed to replace all the things people my age and older start adding to their daily routines, like day creams, eye creams, night creams, neck creams, wrinkle creams, and the dark spot reducers. It's created with the highest quality vitamin C on the market, plus hyaluronic acid, vitamin B5, vitamin E, and other trademark ingredients. It's gentle enough for sensitive skin, but guaranteed to deliver noticeable results, or they'll give you a refund within the first year. Simplify your skincare routine with Vibriance Super C Serum. Go to Vibriance.com/DrPT to save up to 37% off, plus get free shipping. That's VIBRIANCE RIANCE.com/DRPT. Vibrance.com/DRPT to save up to 37% off and get free shipping today. As a doctor of physical therapy, I'm all about optimizing health and wellness. We start to lose collagen, the most abundant protein in our bodies, when we're in our 20s. And that really ramps up after 40. Native Path Collagen can help replenish this essential protein needed for healthy bones, joints, skin, hair, nails, and digestion. Native Path is packed with the types of collagen your body needs most. With just 2 scoops a day, you'll get 18 grams of protein. It's completely flavorless and easy to mix into any drink. There are no fillers or additives, and Native Path is a third-party tested for purity. Get to getnativepath.com/DrPT for a special bundle deal at a fraction of the retail price, plus free shipping. That's getnativepath.com/DrPT. Feel better, look younger, and start your transformation today.
This is Dr. PT Christine Pieton. To participate, call 1-800-375-2872 or email askme@drptpodcast.com.
Welcome back to the Dr. PT podcast. I'm your host, Dr. Christine Pieton, an orthopedic and pelvic health physical therapist. We are going through a series of emails that I've received from listeners over the last couple of weeks and trying to answer as many as I can in this episode. We also have someone who was brave that also threw in a message into the chat, so I'm going to answer Anna's question here. She says, "Hi, I'm pregnant with my first. Congratulations. I'm 35 years old and 36 weeks pregnant today. Do you have any musts for pelvic floor physical therapy that you recommend as I do before or after delivery, and any thoughts on perineal massage?" Great questions. So first and foremost, yes, I have lots of recommendations. So Anna, the perineal massage is one of the things that I do teach my patients, especially for first-time moms. We have research that shows doing perineal massage from about 36 weeks onward, roughly the research says a month. So if we carried a full term, 40-ish weeks, and you subtract those weeks, we get to about 36. I'm often encouraging my patients to start even a little bit before that because we never exactly know when babe's going to come. But 4-ish weeks of doing perineal massage leading up to your delivery is really helpful and shows a reduction in perineal tear rates by about 20%. So that's significant. And I have a video on my YouTube channel that walks you through exactly how to do that. So I would recommend checking that out. The other piece is learning how to push with your breath. So breath work and you learning how to train that with your pelvic floor when you are pushing is another really important skill that I'm always teaching my prenatal patients who are preparing for a vaginal delivery, because how you push and how you use your breath can really make a big difference in terms of how well your pelvic floor can lengthen and yield and stretch, because that's what we need it to do for babe to come through. And if we don't do that well, we can actually encourage the pelvic floor to contract, which is the opposite that we want to have happen. And that can also lead to more significant perineal tears during the delivery process. So I also have a video on that on my YouTube channel, how to push with your breath, that I would also recommend. And then again, our pelvic floor does not work in isolation. So hip mobility and having enough flexibility through the hips is another really important piece that I'm going over with patients. So working on mobility and strengthening and stretching of the hips is also really important in these final weeks leading up to your delivery, because if we have extra tension and tightness in one or both hips, that's going to mean that we have a pelvic floor on that same side that doesn't have the same amount of flexibility as it could. They work together. So I have a pelvic floor birth prep course that you can find on my website at pelvicsavvy.com. And I would recommend checking that out as well. And that goes into more in-depth if you want exercises and things to follow. That could be another resource for you to explore in your prenatal period here. And then final piece, I would recommend reaching out to a pelvic floor PT now in your area if you can, to do some one-on-one work prior, or to at least get on their schedule for postpartum, because most of us around the country are usually booking a few weeks in advance. There are not enough pelvic floor PTs for the amount of pelvises and pelvic floors that need us. So do yourself a favor and you can call and kind of schedule that out ahead of time to support your postpartum recovery would be another tip that I would recommend. So I hope that helps. And Anna, if you have any other questions or things after what I just shared there, feel free to drop them in the chat and then I'll try to answer them as well. So moving back to emails. Another one that I have here is from Lynn. Lynn says that my daughter-in-law is suffering from tight pelvic muscles and pudendal nerve issues. She is being treated by a pelvic floor PT with some benefit. This is painful and has affected her quality of life. Any other treatment or specialist she should consult? Thank you. Pudendal neuralgia, or irritation basically to the pudendal nerve, is a really challenging diagnosis. It is very painful, as was mentioned, and it does really significantly impact people's quality of life. Tight pelvic floor muscles can contribute to compression and tightening around that nerve, and nerves do not like to have tension and compression. They want to have enough space and they need blood flow. Otherwise, they also get angry. And so this is where pudendal neuralgia comes from, or basically that's the title and the diagnosis that we're talking about. But this is what always happens when I'm talking with patients who come in with this diagnosis. I go, pudendal neuralgia tells me that you are having significant pain in your pelvic floor, but it does not tell me why. Why is the important piece that we have to figure out and get to the root cause in order for this to move on. So treatment in this case, and answering Lynn's question, I go, what is driving the pelvic floor tension? So we might need to work on what we call down training, lengthening the pelvic floor. We might need to be addressing and working on tension on either side of the hips that are also creating tension through the pelvic floor. We may also have some challenges and issues with our diaphragm and respiratory function. If we have a lot of tension and tightness through the diaphragm and the rib cage, it doesn't matter how much work we do down at the pelvic floor and the hip level, that's only going to get us so far until we address the respiratory issue. So again, we got to figure out what's driving the pudendal neuralgia in order for us to really be able to make progress. So pelvic floor PT is still important. And like I've said in other emails today, if we've been working with a pelvic floor PT and we're not making progress, then I would encourage you, A, to have a conversation with that pelvic floor PT if you haven't already, to express what you're feeling and noticing, ask for further clarification, ask them for an updated understanding of what you guys are working on and what they think is going on. That'll give you good information. Are you guys on the right track? Or does it feel like that PT might not have additional tools that you need to continue to help you further? We might need to look for another pelvic floor PT, okay? So if we're not making progress in any area after a reasonable amount of time with a provider, it's important to have that conversation and also to recognize we might have to seek out care with another provider who can pick up where that other one left off. Another big piece here too, I would say if someone has pudendal neuralgia, I'm also usually asking and curious, have we had a history of any pelvic surgeries? Because sometimes scar tissue and other things might also be contributing to this nerve issue. And that needs to be addressed as well. Pelvic floor PT should be able to help with that as well. Another piece too, speaking of the pain management piece, sometimes we really need to get some better pain management on board for PT to be able to make progress. So sometimes this involves, some very specific kind of nerve blocks and things like that in and around the pudendal nerve. So this would need to be facilitated by urogynecology, gynecology, or a pelvic pain specialist. These are the more common providers that are usually skilled in this. That's not an exhaustive list, but those are kind of the main buckets that I would start to explore first and see if that hasn't been explored yet. And then once again, I'm always thinking of what we call differential diagnosis. So we have pudendal neuralgia that's telling us we have pain somewhere, but again, what's driving it? And are we sure that that's the issue? So the other piece, when people are having this discomfort and we're not making progress, I'm also then suspicious, do we have pain referral that might be coming from the spine that is looking like pudendal neuralgia, but is it actually a disc herniation or a nerve entrapment from the spine? So if we haven't had additional imaging of the spine, that would be something that I would recommend to rule in or rule out. Are we treating what we think we're treating? Other piece here too could possibly also involve the situation that endometriosis, if that hasn't been ruled out, endometriosis can also sometimes cause other, kind of scar tissue and things like that throughout the abdomen and the pelvic floor that can also then create pelvic tension and tightness that can then create pudendal neuralgia. So that needs to be supported before we're going to be able to make progress on the pudendal nerve situation. So not to overwhelm Lynn and her daughter-in-law, but to say, hey, there's more here to this picture of the tip of the iceberg being pudendal neuralgia, but underneath the surface of that iceberg, are we looking at all of these other things? So I hope that can give some additional insight into what you guys are navigating. And I hope that your daughter-in-law gets to feel better soon, because that's a really, really, really painful diagnosis to be navigating. All right. Let's see here. I'm going to go, let me check the chat here. We got a couple of things going on. So there is a question from Denise. Denise says, what can you use to firm up the stool? When my stool is too soft, then I have a harder time passing it. Any suggestions? Yes, so we need a good consistency of our bowel movements for them to be able to pass easily. So if we have really, really soft stool, we may have a fiber issue. We may also have some food sensitivity issues. We also might have some hormonal changes that are also impacting our gut and gut motility. So, but first and foremost, fiber, and making sure that we're getting enough of it and enough of it spread throughout the day. So what is enough? A lot more than most people think. So on average, the adults are supposed to be getting around 25 grams a day. Now, I will tell you that the average American gets about 10 grams a day. So you have to be really diligent, more than most people think, to get enough fiber throughout your meals of an entire day. And we also want to be thoughtful that we don't eat too much fiber in one sitting or in one block of time, because that can also have the opposite intended effect. If we take in too much fiber too quickly, then that also backs us up too. So that doesn't help. So checking in, and what I often have my patients do, is track a little bit of their food through about 2 to 3 days to get an idea of how much fiber they are taking in, and trying to then be able to improve if they are significantly under, or notice what meals they might need to be adding a little bit more fiber to. Okay. The other piece, psyllium husk, is another really great one that I will recommend to patients to incorporate in to help with that. And just noticing that we're getting enough good, fruits and vegetables, things that we need to really chew, matter a lot, because they usually have more fiber in them, but we also have a really important reflex for our GI system and our digestion that starts in the mouth. We actually need to chew a decent amount before that food goes all the way down to help stimulate that whole reflex. So chewing is just as important as the fiber that we're putting in, as well as the hydration, so water throughout the day, as well as incorporating some electrolytes into that to be able to help, especially as we're getting into warmer seasons, depending on where you live. Just water might not be enough based on a lot of different details. So checking on hydration, checking on your fiber intake, spreading those out throughout the day. And then the other piece, getting some good movement in your day. At least a 10 to 15 minute walk daily does wonders for the GI system, truly. So getting out and moving also helps your GI system to move well, which is also going to help with bowel movements being more consistent and easier to eliminate. And then lastly, Denise, if you're not already doing this, is to also look for a squatty potty. So if you don't already use that or don't know what that is, look it up. Those are really helpful also for helping to improve all of these things. All right, so I hope that helps. All right, I am going to tackle one last email here. Let me see, which one have we not really talked about? I'm going to dive into this one, since this one is another one that I'm often educating a lot of patients on in my office. So this is from Carrie. Carrie says, I'm a 63-year-old woman who was diagnosed with prolapse, and I have stress urinary incontinence with a bladder neck funneling issue. The tissues that are holding my bladder in place are lax and loose, and it appears that my sphincter muscles are loose too. I have numerous pessaries I've tried over the years, but unfortunately it seems like I have to choose between whether or not I want the support for my pelvic floor, or when I wear the pessary, it sometimes causes a loss of being able to control the stream of urine. So I'm then leaking because of the pessary. She said, I'm very fit and thin. I teach Pilates and I exercise a lot, in caps. I also mention this because the literature says that we need to exercise, eat well, and lose weight to help with these things. She says that I've been seeing a pelvic floor therapist and doing a lot of exercises. My current path is that I'm looking into urethral bulking along with the pessary. I've been told that eventually I will need a full hysterectomy, a pelvic floor sling, as well as a urethral sling. I know that recovery for this surgery is very long, and I just don't want to be down and out for that long. So, Carrie, you're doing all of the things to help support yourself. So first and foremost, I think that with the bladder neck funneling, getting some of the urethral bulking procedure done, I find for a lot of my patients, gives them the support and the appropriate closure of the urethra so that we don't have the leaking. And then in addition to that, adding the pessary afterwards, often we have a more successful outcome of not having the leaking from the pessary and also having more of that closure pressure from the bulking material that they are able to insert around the urethra. Usually, I find, and what my surgeons have told me, that the shelf life for that kind of bulkamide is usually around 3 to 5 years. So people usually need to have updated procedures of that, but the outcomes are quite good. And I've had a number of patients that have felt that, in their words, it has been life-changing to have that. So you may find that doing that plus the pessary may give you, additional time before you need or even have to consider the more invasive surgeries. If you decide to go down the more intensive surgery route, like I've said earlier, get more than one opinion. Ask more than one surgeon who does these things, and also ask them what are their outcomes, what is their, percentage of success, what is your personal definition of a successful outcome. Like, have a conversation with that surgeon together to make sure that you guys are both on the same track. Also, a big question that I'm always recommending lots of people do before they consider surgery, and also with a surgeon, is ask that surgeon, do they work with pelvic floor PTs or not? If they don't, or don't think that pelvic floor PT is important post-operatively, that's a red flag. Find a different surgeon. You want a surgeon who's doing a pelvic surgery that is pro pelvic floor PT because they understand the importance of surgery plus rehab. That is essential. Okay. Other piece on that. You said you've been working with a pelvic floor PT and doing lots of exercises. Sometimes strengthening isn't enough to solve some of the structural issues, like we've mentioned, about the suspensory ligaments and the urethral sphincter support and all those kinds of things. So I'm glad that you're really fit. I'm glad that you're active and that you take care of yourself. And sometimes we still need some additional external support. So just know those pieces. And I hope that that gives you some additional insight into what questions you might want to be asking your providers as you continue to navigate your health around these things. All right. So with that, I'm going to pause here. I got through everything except 2-ish emails, but most of those topics were also incorporated into some of the other ones. So I'm going to call it a wrap and say that we did all of it. So I want to thank everyone who has been part of this podcast. Big shout out to Dr. Laura and the Take on the Day team for making this even possible. They were the ones who spearheaded this idea. They were the ones who approached me and said, hey, we want to help more people know about their body. And I said, sign me up, let's do it. So thank you to everyone who made this happen. Thank you for all of the people behind the scenes. I get to show up here, but all the tech and all the things that make this happen are outside of my hands. And so the team that gets to put that together and that has been behind me, thank you to all of you, because otherwise no one would have gotten this information. And as I mentioned when we first started, this was the last episode of season 1 of the Dr. PT podcast. I was your host and am your host, Dr. Christine Pieton, an orthopedic and pelvic health physical therapist. I have never done a live show or had my own podcast. So thank you for joining me over the last 9 episodes. Today was number 9. In doing something new. Doing something new is kind of scary. But you know what? I'm really glad that we did it, and I'm really glad that we got to put this extra information out there and hope that you all learned at least one new thing about your body and how you want to better care for it. So I hope that you can use these episodes as resources to go back and listen and have better knowledge to know how to care for your body and to be better informed when you need to navigate our healthcare system and ask your providers more thoughtful questions so that you feel more empowered when you make your next best decision. And as I say every week, but I will say it again, keep moving well and keep moving often. And I look forward to staying connected with you here on YouTube. If you haven't already, feel free to subscribe so you can stay in touch. Or you can find me on Instagram at Pieton, PT, and we can stay connected there. I hope that you all have a great rest of your Monday, and take care and keep moving well.